Hello and welcome to a Drink Drug Hub training session. Drink Drug Hub is a place where you can get the right information about drink and drugs. The website is drinkdrughub.co.uk and you'll find videos, tools, resources and web pages there, all at that website, as well as live training sessions you can book and recordings such as the one you're attending today. Now, the one we're looking at today is drug support, and drug support is the third module in our drug series. It's slightly longer than the previous two, and in this session we'll look at all these learning objectives. So we'll look at what we mean by recovery as a goal for people to work towards if they're using drugs and struggling with them. We'll look at the support that's available to help them get there, including treatment services, rehabs, mutual aid groups and virtual support. So we'll ask which is most effective, and then we'll look at pitfalls that people can fall into and how we can maximise the chances of helping them when we're trying to provide this support. Now, before we do that, we need to do a quick recap of session one, and that was called Drugs Think Different. And this is all about how we perceive drugs, and how we perceive drugs is very much about the messaging we've been given around them. So in that module, we looked at heroin in the 1980s, cannabis in the 1930s, and crack in the 1990s, and the messaging that was really in the public sphere around those specific drugs, all of which really oversimplified the harms that they presented. And following that on from today, we can look at drug support. And what we find here is that responses to drugs have also been hugely oversimplified. And some examples of that are here. So in the 1980s, we had Nancy Reagan's Just Say No campaign, which told people they should just not take drugs. And then more recently in the 2010s in the UK, we've had the rise of the recovery agenda, which came with many positives, but also came with some ideas about avoiding being parked on methadone. In other words, not staying in drug treatment for too long. The ultimate aim was to avoid drugs and only need treatment briefly before living a drug-free life. And that drug-free life, again, has been oversimplified a little bit, has been an overwhelmingly positive experience. It's our concept of recovery. Now, recovery is, for many people, a positive experience, but it's potentially not as one-dimensional as sometimes it's portrayed. So you can find lots of videos and clips on YouTube and resources out there exemplifying how great drug-free life is, and actually drug-free life can also be quite hard and tricky. But you might think, what is wrong with telling people how great life can be if you're drug-free, because this is surely a motivating factor for people and this will help motivate them. And that's true for some people, and we should definitely run with that for people for whom that works. But for some people, the more we tell them about how great drug-free life is, the more it can feel like this. So this idea of recovery can feel a bit like a cliff face that they can't climb up and get to because it doesn't seem achievable for them. Now, of course, we have a solution for that. We can put in a ladder for them to climb and say, step by step, we can get there. But then there can be problems because people might not seem to engage with that support that's being available. And this is where it can get quite toxic and backfire, because then we get into blaming language and we start blaming the person for not helping themselves. And we can see that in how we talk about them. And the word to look for is fail. So we talk about failing to attend appointments, failing drug tests, failing to change. And then we start thinking, well, if they fail to change, it must be they don't want to change. And if they don't want to change, it's because they don't want to stop taking drugs. And what you find is that services intended to support people in this way actually withdraw because they feel that this person, for some reason, doesn't require that support or isn't engaging with that support. What we find is actually the problem isn't that person. Really, when we analyse these cases, the problem is more likely this, that the support wasn't the right support for them, and that's why they weren't engaging with it. So the first half of the session is actually going to look at what does the right support look like. And to that degree, there's 4 types of support we'll look at in detail. The first are treatment services, then mutual aid groups, 12-step groups, things like Alcoholics Anonymous and SMART meetings. Then we'll look at detoxes and rehabs quite briefly, and virtual support as well. So to begin with, we'll take a quick look at treatment services and what that looks like in North Yorkshire. So we've got 2 services that run in North Yorkshire. We've got North Yorkshire Risings for adults and NY Rise for young people. Now, the young people service is really important, and we'll explore that in a different session in the future. In the meantime, most of today will be about adult services and North Yorkshire Risings. Now, how that looks across North Yorkshire is we have 5 hubs that we work out of. One of them is a community hub, the other are 4 are our own offices. So they're based in Northallerton, Scarborough, Harrogate, Skipton and Selby. That's where you'll come for your appointments with your recovery workers, but sometimes we'll do home visits or meet people in other places that are convenient and comfortable for them. NY Rise works out of Harrogate, and they will always meet the young people in a comfortable place for the young person. You can also see little pharmacies dotted around this map here. The pharmacies are the places that will actually provide the medications that we prescribe, so they won't collect them from our offices. They'll go to their local pharmacy to do that. And if the pharmacy has any concerns or observations they feel they need to feed back to us, they'll do that so that we are aware of how people are managing the community. So that's broadly how the service looks across the county. Now, in terms of the detailed look, there's quite a few different parts of the treatment service that are worth knowing about. The first are support sessions. So when you come in to get some help, you'll have assessment, you'll get a recovery worker, and they will arrange support sessions with you. They will use cognitive behavioural therapy approaches to help you. So CBT is all about understanding your thoughts and feelings day to day and how they influence the choices you make. It's different to counselling. It's not really going back into your past and unpacking that. It's very much living in the here and now and trying to make different decisions for the future that better align with your goals. Now, interestingly, the first thing a recovery worker needs to do is to build a therapeutic relationship with someone. For CBT to work effectively, that's an absolute core principle. And you'll know if you have a therapeutic relationship with your recovery worker if you feel valued by them and if you feel they're invested in your recovery. Now, in terms of its success, there's a lot of different papers out there analysing CBT as an approach not just for substance use, but also for mental health conditions as well. But specifically around substance use, this is what success looks like according to the research. So you provide CBT for a period of time, then the person is discharged from treatment, and a year later, somewhere between 15% of people to 60% of people are still abstinent from their drugs. Like I said, there's lots of different research papers out there, so there's somewhere within that broad range. CBT is often seen as the gold standard within treatment services, so all treatment services in the UK will generally conform to that as the treatment models they work to. So that's your one-to-one support sessions that you'll have with your key worker, but we also have groups. Groups are educational settings, so you'll go there to learn about drugs together, learn about addiction, and we will deliver courses through group work for people as well. And then we've got our clinical team. So our clinical team are made up of nurses, and they will provide health and wellbeing screens for everyone involved with our service. So that's a general health checkup, screenings for bloodborne viruses and dressings of wounds, as well as measurements of height, weight, blood pressure and general health surveys. Now, for people who are on heroin or other opiates, we can look at opioid substitute therapy. So this is really methadone or buprenorphine, which we're going to look at here. Now, you can prescribe those for people who are physically dependent to an opiate drug. That means they go into withdrawal when they don't have it. And we covered that briefly in Module 2 in Drugs Guide. We looked at what withdrawal looked like. These symptoms come in if you've been without your drug for a period of time. So you start sweating, vomiting, or having tremors, chills, or diarrhea. To prevent that, you can go and take more of the drug, but obviously if you're trying to stop taking drugs, that's not an option you really want to explore. So we can support someone by giving them a medication instead that will keep them out of withdrawal. And the really good thing about these medications is they're long lasting. So you can take methadone or buprenorphine to prevent withdrawal if you're on heroin. And we also now have an injectable form of buprenorphine called Buvidal, which will last for a whole month. But the main treatments that we look at would be methadone or buprenorphine, and the advantage here is they last 24 hours. So you only have to take the dose once a day. Now, this is how this looks in practice. There's methadone. It's generally prescribed as a liquid that you drink, and buprenorphine is a sublingual tablet, so it dissolves under the tongue. In terms of which one, clinical guidance says the patient should feel empowered to make their own choice about the medication that's best for them. There are some key differences between them. Buprenorphine is a complete blocker, which means you won't feel euphoria from heroin if you use on top of it. whereas methadone is not, so people may use heroin on top of methadone. Methadone also can leave you feeling a little bit woozy-headed, whereas buprenorphine you'll feel clear-headed. So again, that might be an important distinction to think about. For instance, if you're suffering a lot with trauma and psychological pain, methadone might actually be the preferred treatment for you. Whereas if you're working, have childcare commitments, and need to stay clear-headed, buprenorphine might be the better choice. In any event, when we know which medication to use, we will start titrating it up. So you will start at a low dose and build up. This is because there's a higher risk of overdose when you start these medications before you build full dependency. Just as a small detail, with buprenorphine, you need to be in withdrawal before you start titrating up. Once you're at a dose where you're stable, you can then stay at that dose for a length of time just to get used to it. We know that you've stabilized if you're not in withdrawal any longer, but you're not intoxicated. So that's what we're looking at. And then once you've stabilized, you can make a decision about whether you want to stay at that longer term, because that medication is helping you and is helping you keep your life in balance, or you might choose to reduce down and come down off it. Now, in terms of dosages, the guidance again is quite clear about this. So a therapeutic dose of methadone, which should keep you out of withdrawal, will be somewhere between 60 to 120 mils, and for buprenorphine, it would be between 12 and 16 milligrams. If you're significantly under this, there has to be a good reason for you to be under that. Otherwise, it's probably not working to its best for you. The other really important thing about clinical guidance is it says if people continue with profound cravings for their drugs, then that might be an indication to increase the dosage further. So if people are using on top of their script, that's one of the things that we should discuss. And in terms of the goal, clinical guidance also says that we should treat these as equal value, whether someone chooses to maintain or reduce. Now, whether it works or not, the evidence is pretty clear on this. And it says, yes, this is a really good intervention for people using heroin. If you take it as prescribed, so daily at the right dosage, then it actually reduces mortality risk somewhere between 50% and 75%. And it also is effective at eliminating drug and alcohol misuse, but that might take months or years to achieve. This is not necessarily a quick fix for people. So the evidence is really clear that this can be very beneficial for people. And it certainly helps keep them safe when taken as prescribed. But methadone also has a bit of a reputation attached to it. This image that you can see here is actually taken from a drug rehab website, and it's often seen as swapping one addiction for another, and it's challenged as to whether this is effective or not. So there's a lot of ideas going on methadone that actually put people off going onto this drug that could be really helpful for them, and also the same for buprenorphine. Now, in the full live session, we watched this video. We can't play it in a recording, but you can go and watch it at Drink Drug Hub. It's the video that stars Dr. Adam Winstock of Global Drug Survey, and in it, he advises how to know if you're on the correct dose of methadone or buprenorphine, and it also challenges lots of misconceptions about these drugs. And he advocates that people really should try and be on these medications if they have problematic use with heroin in particular. And that is well worth a watch, and I'd recommend going to drinkdrughub.co.uk to have a watch of that video. In the meantime, for people who really don't want to go on that medication and maybe don't want to engage in the treatment service at all, there's still a part of the service that would be really useful for them to consider. It's available for anyone. It's our needle syringe provision. This is where people can come by the service to get free sterile equipment for taking drugs in a less harmful way. They don't have to sign up as a client with us. They don't have to commit to regular appointments. It's really useful if they bring back their used drug taking equipment so we can dispose of it safely, but then they can collect more sterile equipment, which will really reduce the risk of bloodborne viruses and other harms that they may be exposed to. So that's the treatment service, but it's not the only way that people can be supported through their drug misuse issues. We also have mutual aid groups. So mutual aid groups look like this. Small meetings of people, often in church halls and community centres, all of whom have drink or drug issues, meeting together to discuss how they are and different strategies for managing their use. This was popularised by Alcoholics Anonymous, which we're going to look at in a second, But this is how you will find those groups around North Yorkshire. There's different links that you can see on the screen. You can go to Google and just put in Alcoholics Anonymous, Narcotics Anonymous, or Smart Meetings, and you'll find the link for a meeting near you. You put your postcode in and a map will come up telling you where you can go for a free meeting to attend. This is what it looks like across North Yorkshire. As you can see, there's multiple meetings going on every week across the region, mostly Alcoholics Anonymous meetings and Smart Meetings, with 1 or 2 Narcotics Anonymous meetings as well. And these meetings are also widely available online. So in terms of how these meetings came around, it's worth knowing a bit about this man. This is Bill Wilson, and he was one of the co-founders of Alcoholics Anonymous. He was a 1930s New York stockbroker. He had a really big problem with alcohol. He almost died several times from his drinking. And he said, the problem for me wasn't that I couldn't stop drinking, I just couldn't stop myself starting again. Eventually he managed to stop drinking, and he found it was really helpful for him to try and help other people to stay stopped. It helped him stay sober. So he had a bunch of people who would meet together, and he said they were just a bunch of drunks trying to get sober. But over time, they developed a pathway that other people could follow to get sober like them. And this became what's now known as the 12 steps. So the 12 steps are what you can see on the screen there, starting with admitting you're powerless over addiction to finding the 12th step of spiritual awakening. And if this sounds quite spiritual in its origins, it's because it is. It's based on a model from an evangelical Christian group. Some people really like it, and some people find that quite hard to work with. In which case, they should probably think about smart recovery groups. These are similar in terms of settings for people to meet and discuss how they're doing and to help one another, but they follow a CBT-based approach rather than a 12-step approach. Now, in terms of does it work, most of the research in this area, in fact all the research that I've come across, actually refers to 12-step models. But again, what we're looking at is people meeting together and sharing their stories and supporting one another. Where this has been researched around 12-step models, success has looked like this. It depends where you look for the success rates that you find. So if you look at AA directly, what they will tell you is 75% of people who attend Alcoholics Anonymous meetings stop drinking long term. Independent researchers put the figure at 24%, whereas critics say it's somewhere between 5 and 10%. Again, there's lots of variability here. The most reliable figure is probably in the middle there at 24%, and it's worth saying that actually the control group in that research of CBT-based approaches was the one where people were managed a 15% success rate. So it was actually a more effective intervention than CBT in this case. What's really important is what the researchers had to say about how they felt this worked. They suggested that maybe the 12 steps themselves weren't the critical ingredient to success. Rather, it was about the relationships people built and the acceptance that they felt among one another. They said actually the human need to belong and be accepted is really critical to long-term recovery. And we can see that in lots of places, and unusually we see it here, just to demonstrate how important it is. So this is a podcast. It's called the Davey Podcast. It has a tagline called the podcast you wouldn't take home to meet your parents. It's quite rude, it's quite sweary, and it was set up by the two men you can see on the screen here, Dave and Chris. These were two friends that met in the rehab. Dave's from New York and Chris is from Boston. They wanted to tell wild drug stories. It was actually an anti-recovery podcast to begin with. Tragically, Chris has actually died since the podcast began. He relapsed and died in 2018 from an overdose, but the podcast continues to today. And what's really interesting is that since the podcast started, people have gathered around it and started supporting one another. And what's developed over time is a whole community of people helping one another. So what started out as something of an anti-recovery podcast where they didn't want to tell recovery stories has become itself something of a recovery movement. So listeners have built a Facebook page and they get connected with each other over Facebook, and now at the present time they host over 26 Zoom meetings a week, all helping one another, because as they've got to know one another, they've wanted to help each other. And that tells us a lot about the human need for acceptance and support for one another. We know that being part of a community can be really helpful to long-term recovery, and actually that's probably most useful for those with the most severe addictions. It's also worthwhile pointing out that this is available for free, so if people aren't engaging with the support, it's really worth exploring the barriers preventing them accessing something that could be really helpful for them. Now, the next support we'll look at are detoxes and rehabs. Now, there's a critical component to these that you won't find elsewhere, which is it's a place to get better in terms of it's a place of safety. So if you have a very chaotic life, lots of things going on that you're struggling with, either in your external life at home or inwardly in your head that you really can't manage very well, then these can be really useful facilities as a place of calm and a safe place where you can work through the issues you need to work through. Now you can get there through a recovery service like North Yorkshire Horizons, and that's the process we would follow there. Your recovery work would identify with you that this is the correct intervention to look at and would make an application to a panel of managers. They'd do lots of preparation work before then, including a really thorough aftercare plan for you. And the managers would approve the funds needed for you to go to a detox or rehab. Now, in terms of how many placements they approved, in 23-24, that amounted to 4 rehab placements and 19 detox placements. So not huge numbers, but this is available. The placements that we're tied into are in Manchester, Staffordshire and Runcorn. So this is how you would get there through the recovery service. You can also make private arrangements to go there, either paying for this privately or through health insurance. And most people in this case end up in Google, and it's often family members and friends that arrange this. So you go to Google and have a look through whatever comes up and choose your provider from that. But this is where you need to be careful, because independent providers can promote whatever treatment they see fit and they market that directly to the consumer. So there's quite a lot of money being made in this sector. We need to be careful as consumers about making wise choices around that. Now we do know that within rehabs there are some potential issues to be mindful of. There are some cases of therapy being used that are known not to work, like confrontational therapy, which is very much about trying to disassemble someone's ego by confronting them about the things that they struggle with. We also know the therapies are sometimes used that lack a rigorous evidence base. So you will find things like Reiki and sound bath meditation. And then finally, the most common treatment model used in rehab is actually the 12-step model. And as we've seen, the 12-step model is available for free already. So you don't have to pay to go to a rehab to access that. You can go to your local church, church hall or meeting room, and you'll probably find a group there that you can attend. Which gets us this question about why would you go to rehab then? And the answer is here, surprisingly. So this is an article by John Crace, who writes for The Guardian as a political sketch writer. He wrote an article all about heroin addiction and the role of rehabs, and the 12-step model in particular. And what you find is as he's writing about this, he's actually talking about himself. John Crace himself was addicted to heroin for 10 years, and he attended a rehab in 1986, and he attributes his recovery, his ongoing recovery today, to that really critical time in his life where he went to a rehab and the 12-step model since then. Now we know that rehabs work very well for some people. This is actually what you're looking at here are the reviews on Google of the rehab that we most commonly use, and they're generally overwhelmingly positive. You can also go to clinical guidance, and clinical guidance will tell you that those who complete residential treatment programs often have better outcomes than those who do not. However, there is a mixed evidence base because, as I say, there are some practices within rehabs that maybe aren't working so effectively. So what we would say if you are going to arrange this privately is make sure you go to the CQC and you look at the inspection reports. So the CQC website address is there, and you would go on there and type in the name of the provider and it will rate it for you to tell you how well it's performing. So North Yorkshire Horizons, for instance, will only be sending people to rehabs that are rated as good or outstanding. Finally, we've got virtual support. This is the last support we'll look at today. So with virtual support, these are apps that you can download on your phone and go through recovery tools on the app, working towards goals that you have set yourself for your drug use. It will come up with a personalised plan, and you can use this app whenever is convenient for you to help you progress through your treatment. Now, in terms of its success, it's quite a new intervention, but there are various research papers out there. I've looked at the research papers that apply to the treatment app that we use, which is called Breaking Free. And as you can see, these were overwhelmingly positive. It's been proved to work quite effectively for a talking therapy service, also for a prison population and a recovery service in the UK. Now, with that final study, I should point out that some of the authors of that study are themselves employed by Breaking Free Group. So even so, the most common phrase you'll come across in these research papers is that this intervention may help. In actual fact, when you read them, you tend to find a bit more positive than that suggests. It's definitely worth exploring that as an intervention. You can get that app. You can get the code to access the app for free from North Yorkshire Horizons. So that's another intervention to think about. So these are the 4 we've looked at. And just to summarise each in turn, we can look at how most effectively to use this support. So if you're accessing a treatment service, this works best when you have a good relationship with your worker, where you feel valued by them and you feel they're invested in your recovery. If you don't feel like that, that's the thing to draw to the attention of the treatment service so it can be addressed as a treatment need to enable you to get the best out of that CBT approach. Now, if you're on methadone or buprenorphine, you really need to be on the right dose for that to be effective. Now, that video that if you do watch it will tell you is that historically we've had a bit of an issue in terms of underdosing people. So maybe the dose needs to go up for some people for them to really benefit from that medication. For mutual aid groups and 12-step models, these work best when you feel accepted. If you go to a group and don't feel accepted there, it's worth trying different groups until you find a group of people who you feel you really kind of gel with, because those relationships are critical to the group working well for you. And the more serious an addiction is, the more beneficial a mutual aid group probably is. Detoxes and rehabs are worth exploring when you need a safe space in which to work on your recovery. You should look at one that uses an evidence-based therapy and make sure you read the CQC report beforehand. Meanwhile, the virtual support, these apps do seem to work quite well. The research suggests the more you use it, the more you can benefit. And also something I should add there is the research also says that if you have a mental health issue, particularly something like depression, that person probably needs additional help to get into the habit of using the app. It's no good just downloading the app and giving it to them and expecting that they will use it effectively straight away. They may need lots of help for this to really embed as a habit for it to become beneficial. So to summarise that first part of the training session, what we've looked at is all the different support that can go into building that ladder for someone to help them get to that goal of recovery. Now, to look at how this works in practice, we've got a hypothetical person to work with. And we've got Darren. So Darren is this guy here. Now, Darren's been using heroin since teenage years. And what we're going to do now is get him to go through these support options to see how this works for him. So he's going to call North Yorkshire Horizons and we're going to work through that step at a time to see what a recovery plan looks like with all the different support in place and how effective that is. So first of all, Darren's phoned Horizons and he's got himself a recovery worker, as we talked about a moment ago. He's going to meet with that recovery worker frequently to try and build up that relationship. There isn't really specific guidance about how little or often you should meet with your recovery worker, but as we've seen already, it's really important to build up the relationship. So at least the first 6 weeks, it's probably worth trying to see them at least once a week. So for Darren, every Monday at 3 o'clock, he'll meet with his recovery worker who will use CBT-based approaches to help explore his current drug use. Now, because Darren is using heroin, he's also going to take methadone. It's very strongly recommended to explore methadone or buprenorphine if heroin is the problem, a substance, and it's being used at a point of dependency, which means you would go into withdrawal without it. Now, in Darren's case, this is true. So the nurse is prescribing him methadone. And to begin with, he'll collect that every day. And that's because of the risk of an overdose as it's being titrated up. So we don't want people taking too much and overdosing because of the drug that we're prescribing them. So you go collect it every day and drink it in the pharmacy with a pharmacist observing, so we know that it's been taken correctly and you're safe. But then the clinical guidance also says as soon as you can and as soon as it's safe, someone should go to weekly collection so that they only have to go to the chemist once a week to collect it and take it home with them. There are some things that may prevent that happening. So for instance, there may be children at home and no guarantee of safe storage. And this is a lethal drug in the hands of children. So that might prevent that happening. If you do have children, there needs to be an assessment taking place to make sure it can be safely stored. You may have memory issues, which means you're more likely to forget to take the methadone, or you may, for instance, be homeless and not have anywhere safe to actually store it. But in most cases, it's expected that people will be able to go to weekly collection of their methadone. Now, the other thing that's important for Darren is mutual aid groups. As we've seen already, he's been using heroin since his teenage years. This is a long-standing addiction, so he has a lot to potentially benefit from by attending a mutual aid group. And he's going to give Narcotics Anonymous a go and Smart Meetings a go. So he's got 2 appointments there every week for those meetings. And in between, he's got an app on his phone. These are really useful, as we've seen, because they're available at any time. He can use them at evenings and weekends and look at his recovery journey using his app. Now the question is this: if Darren works hard and he takes his methadone and he attends all his appointments, what happens next? Well, we know the story around drugs that we tell ourselves, and particularly around recovery. We say if someone puts the hard work in, then this is where they get to. They inevitably get to live drug-free. And as you can see, that's very much part of the messaging we have around drug support. There's a common 12-step saying, which is if it works if you work it. In other words, if it isn't working, it's probably because you're not the one putting the effort in. And you can see this with CBT approaches as well. There's a talking therapy workbook from 2004, and it said, look, you're responsible for your own actions. If you want to give up, it's up to you. So it's very much down to you to make these decisions. You can go to Google today and put in the phrase responsible for your own drug recovery, and you will find a whole selection of articles, mostly written by rehabs, telling you about how you need to take responsibility for yourself. Now that's really interesting because in terms of drug treatment, we put the responsibility on the person receiving it for ensuring it's successful. And that's a bit unusual in terms of treatment interventions in general. So for instance, if we look at cancer care, you wouldn't have a doctor telling a patient that the chemotherapy didn't work because they didn't seem to want it enough. There isn't that concept there, but there is with drug treatment, which gets us to this point. How do we know that someone wants to change, and how are we measuring that? On the surface, this is quite straightforward. We think it's about someone using drugs. If someone's still using drugs, that's evidence that they don't want to change. But we need to challenge that as a perception. So for instance, we can look at the story of Matthew Perry. Matthew Perry had a very traumatic life in terms of his addictions. He was addicted to alcohol and painkillers, and he estimated he went through over 60 detoxes in total. This is a quote from his autobiography, published a year before he died. He said he spent upwards of $7 million trying to get sober. He'd been to 6,000 AA meetings, rehab 15 times, and had been in a mental institution, as well as going to therapy twice a week for 30 years. Tragically, Matthew Perry died having taken drugs, and this was seen as sort of a personal failure in some parts of the media, as if actually he wasn't trying hard enough to stay drug-free. And what we would say here is this evidence here suggests that he really did want to change, and he'd spent a life trying to work at being drug-free. The fact that he relapsed many, many times isn't necessarily evidence that he didn't want to live drug-free. So we would challenge that perception by saying ongoing drug use and relapses may not necessarily mean someone doesn't want to change. Addiction, after all, is defined by an inability to change a behaviour. So if you see someone still relapsing, it's really just defining the problem that you know they have already, which is addiction. So if it's not about failing to stop, we have to question, is it about failing to try? And when it comes to trying, we think of it as this way, that if someone doesn't try, then the interventions we're attempting don't work. But we're going to challenge that as well, because we're going to rerun Darren's journey through the recovery surface. In this case, his engagement isn't going to be as successful as the first time. So He rarely attends his CBT therapy sessions, doesn't always collect his methadone, sometimes attends his mutual aid groups, rarely looks at his virtual support app. Now, the question we want to explore here is, why is he engaging in this way? And the point is this, that his past experience may tell him that these interventions don't help. After all, he's been using heroin since his teenage years. It's very likely he has experience of these interventions already. And furthermore, we know there's been a skill shortage in the drug sector over the last 10 or 20 years. So it's quite likely, if he's been involved in drug treatment services over that time, he will have had experience of CBT being delivered to him incorrectly and not effectively. And we also know there's been a practice of underdosing methadone and buprenorphine, so he may have had these medications before and found them unhelpful because they haven't been prescribed at the correct dose for him. It's also important to bear in mind someone's wider life experiences beyond just drug treatment services. So if we put someone in a learning environment, such as a group, and yet their past experience of schools and other learning environments is not positive, it's likely that that is going to be a bit of a hurdle for that person. In other words, the problem isn't they don't try. The problem is, why aren't they trying? And maybe they're not trying because what we're trying to do has been proven to them as ineffective for them before. Which gets us to this point, like, what can help Darren now if everything we're trying to provide isn't really useful for him and he doesn't find it beneficial? Now, when we have people missing appointments, recovery workers would tend to go to a standard exercise to look at, which would be a motivational piece of work like this. It's called the pros cons exercise. It's where you get a piece of paper and divide it into 4. You look at the pros and cons for continuing using drugs and the pros and cons of stopping using drugs. The theory is that you get someone to rationalize their decision-making process. They can see why they're making the decisions that they are. Done well, it can have really effective outcomes. But sometimes we just try and skew it so it looks a bit like this. Like the idea of stopping drugs is all good and the idea of continuing with drugs is all bad. And at this point we have to challenge this idea about what are we trying to achieve with that exercise. Are we suggesting the person doesn't really appreciate the advantages of stopping using drugs? I would say that probably they do understand this already. That's why they're in a drug treatment service. More likely the problem is this: their past experience tells them that the treatment you're providing for them isn't actually effective. In other words, it's reminiscent of this quote here, that insanity is doing the same thing over and over again and expecting different results. In other words, there's no point trying to repeat a treatment that hasn't worked previously for someone unless you explore that a little bit further. That can put you into a bit of a dead end if you don't have other treatments available. But the problem isn't necessarily the treatment you're providing. The problem sometimes is the goal. So this is where we get to this idea of recovery and how that can help people and how we can reconceptualize that in a way that broadens it out as a more accessible goal for anyone who might be struggling with this. And to understand that, we're going to take a look at this place here. This is Chicago, and specifically we're going to look at the Chicago Recovery Alliance. They're really important in the drug treatment world. They were the first drug treatment service in the world to give out naloxone, life-saving medication. They also provide clean needles, advice on safer use, overdose training and harm reduction counselling. And what's really important is they provide a lot of this from this van here. This goes out and about in the community and meets people wherever they are to try and support them directly in the community. The other important thing is the slogan on the side of the van. It's called anypositivechange.org. In fact, if you go to the Chicago Recovery Alliance website, it's called anypositivechange.org. That's the website address. That's their slogan. And the idea is that you collaborate with someone to make any positive change in their life as defined by them. So this gives us lots of different starting points to look at, not just necessarily telling people they should work towards being drug-free, but they should work to make positive changes. And you can go back to our drugs guide session and take a look at any of those guides, and they're packed with useful ways that you can help someone use their drugs in a less harmful way. So for instance, if someone's taking ecstasy, we can talk to them about drinking water. If they use cannabis, we can talk to them about avoiding driving afterwards. If they use cocaine, we can talk about rinsing their nose to minimise harm to the nasal cavity. If they take benzos, we can talk about the idea of using them at a lower dose and spacing out their dosages, otherwise known as low and slow. And amphetamine is an appetite suppressant, so we can talk to people about trying to eat well to stave off malnutrition. So this is really important in terms of other goals that we can work with to help support someone. And we have some examples of how that can work in practice. In the first instance, we've got someone living on the streets. We can talk to this person about using clean needles. That would really reduce the risk of harm from the drugs that they're taking. For the person in the middle, we may talk to them about writing down their feelings. If their drug use is about feelings, they may continue to take their drugs, but we could work around those feelings a little bit to begin with. That could be a good starting point. And for the person on the end here, we could talk about making a plan for them to take their drugs at intervals, planned out in advance. So we get away from the boom bust kind of pattern that we can have sometimes with drug use that can be particularly toxic and harmful, which can be very much led by emotions and self-medicating. But the key here is that we're looking at any positive change. This doesn't just have to be about drugs. And when you don't make it about drugs, you find the whole world opens up. So our person living on the streets, we could talk about their clothing, their dental care. This person has a dog, so we can talk about veterinary care for their dog. And the better we do that, the better we probably connect with him. And also we can talk about getting hot food. The person in the middle, we can talk about other opportunities, interests, and opportunities to meet other people while they're still taking drugs. It doesn't mean they can't do those things. And for our person on the right, we can talk about jobs, holidays, attending the gym, other ways to enhance their life and well-being. So when we're talking about any change, we really are talking about any change at all. This is any change that reduces harm or improves well-being is something that we can collaborate with someone around. And this doesn't necessarily have to be about their drugs. Now, to explain the importance of that, we need to go to this diagram here. Everything we've looked at so far, in fact, most of the research you'll find around drug treatment is about this group of people here. This group of people represent people who attend treatment services. They're quite often the group of people who researchers will flock to if they want to understand drug addiction because they're easy to find within drug treatment services. However, there are other people who struggle with drugs. These are people out in the community who never attend a drug treatment service and yet are struggling with drugs. When we analyse them, we find out some really important information. Mostly, those people most often get better without any help whatsoever. We've spent this session so far looking at the different support available, but actually most people manage to recover from drug misuse issues without support. And that's a really curious message. It's not one we might be used to hearing. I heard about it first in magazine articles like this some years ago. I kept coming across this idea that people aged out of their drugs. In other words, they just grew out of it. And people didn't need expensive treatment to do this. So to begin with general media articles, sometimes these can be questionable and they're not reliable in terms of understanding what the reality is of drug issues. So you can't always trust media sources, but then you'll find it in places like this. The Harvard Health blog also talks about natural recoverers kicking their addiction without help. And then you'll find it in really quite trustworthy sources, like Gene Hayman's work. Gene Hayman's a psychologist who's written a lot about addiction and recovery. And he says in his book that most people eventually quit using drugs at clinically significant levels by the age of 30 and often do so without professional assistance. And again, he's referring to these people as addicts. We wouldn't really want to do that in terms of labeling, but these are people who are really struggling with addiction. And then we've got Maya Salvitz. She says the same thing. The majority of cocaine, alcohol, prescription drug and cannabis addictions end before people are in their mid-30s, and most do so without treatment. At this point, you might be thinking, is this new news? Have we known about this a long time? And the answer is yes. This has been known since the 1960s. A psychologist called Charles Vinnick looked at this in detail, particularly around heroin use. And he found that 75% of heroin users in his study had stopped using by the age of 36. Now, this is so interesting. You can go through the core research and you can find how this is actually studied. The way it's done is researchers will do a big population survey of a large sample of people, in this case 40,000 people, are randomly selected and written to take part in a survey around drug and alcohol issues. 9% of those people had written back in this case, or engaged online to say they did have a problem with drug or alcohol. Half of those people said they've recovered without any help. The next most common way they recovered was through mutual aid groups rather than treatment services. And for people with the most serious addictions, they were most likely to get into recovery by attending treatment services and mutual aid groups together. The other interesting thing is that relapse wasn't the norm. 2/3 of people had resolved their problem 5 years ago, and at the point of engaging the survey hadn't relapsed. That's one study, but these studies have been repeated many times. You'll find these done in 1980, 92, 2002, 2003, with somewhere between 19,000 and 43,000 participants, and they've all come back with similar findings, that actually the most common way people get into recovery or stop having a problem with drugs is without any support at all. Which gets us here. What's the difference here between the person out in the community who's struggling with drugs and the person in the treatment service? And the difference is this, according to Gene Heyman anyway. People out in the community who aren't engaging with treatment services and do get into recovery without support are more likely to have good opportunities for a better life. In other words, if they stop using drugs, this can be really advantageous for them. They have a better life available for them to go and live. Whereas people in treatment services quite often have limited life opportunities and very frequently have poor mental health. And Gene Heyman says this is really important in understanding treatment outcomes. So you can actually look at this data yourself in terms of UK drug and alcohol services. If you look at that, what you'll find is 70% of people attending our treatment services identify as having mental health treatment needs. In other words, this would really back up what Gene Heyman is saying. Having a mental health issue and an addiction issue together really limits the opportunities to get into recovery. Meanwhile, if you look at surveys specifically around people with high employability, around people who are doctors and airline pilots, when they struggle with addiction, their outcomes are really, really good. Over 85% of people from these categories get into recovery. And that's really critical. We know that people are more likely to recover if they still have jobs, family, and greater ties to mainstream society. So that's really important in terms of building up opportunities for recovery. The more you can build up someone's overall well-being and life opportunities, the better they have a chance of managing their drug use. And this is all about how people can get that support to do that. In theory, what we should do is make access to help really easy for people in these difficult circumstances so they can build up their lives better and enable them to stop using drugs if this is their choice. But what we find time and again is actually when people struggle with drug issues is they actually find it quite hard to access support. And this is true of mental health needs, social care needs, and even drug and alcohol needs. Sometimes it's quite hard to access these services. And this gets us here. So the question we were looking at before is which of these interventions is most effective for helping someone who's struggling with drugs? But that might actually be the wrong question to ask. The better question might be about which is best delivered. And this takes us to the final piece of research. This is about how support is delivered to someone. It's really critical in terms of how it's received. So this is a series of articles that were run some years ago now, looking on research about how drug is delivered. And specifically it was looking at research around America. So this is about how people access support, and researchers looked at Texas, Portland, New Jersey, and Philadelphia. And what they did was change the intake procedures for these services. So the support was available faster and more easily for people who contacted the services for help. And what you can see is when the researchers changed these things, engagement really went up significantly. So for instance, in Portland, when people were invited to come as soon as possible for an appointment, instead of being made to wait for up to 10 days, their attendance rate rose from 38% to 60%. Similar rises were seen in New Jersey, Philadelphia and Texas, and this one's really interesting in New Jersey. They found that people were still more likely to attend their support sessions, even if they couldn't attend the next available slot that was provided for them. So even if they still had to wait to attend later on, they were still more likely to come to that. And this is because offering an earlier appointment in the first place probably made them feel more valued, like you really did want to support them, and this made a difference to that person. The other thing the researchers looked at is how people are incentivized to stay in treatment. This is quite important, particularly if people have mental health issues. Maybe they wake up one day and it's a really bad day for them and they really struggle to make it to their appointment. What happens next is really important in terms of whether they continue to engage or not. In this case, researchers looked at the standard letter that was sent to people who missed appointments, and they replaced it with a different letter for a control group to see if that was more effective. Now, the first letter that you can see is a very formal letter, and this is the standard letter that has been sent to people who miss appointments. It says, "Dear Mr. Smith, you failed to attend your recent appointments." There's that word again about failure. "Please contact us to discuss this and whether you still require our support." Then it says, "Yours sincerely, a drug treatment service." And what the researchers did is they replaced that letter with a more personal letter. It said, "Dear Michael, I hope you're okay. You've been coming to all your appointments recently, so when you missed the last one, I was worried about you. Please get in touch to let me know how you are and how we can help. Kate." And significantly, it was signed off by a personal name and not just the name of the treatment service. Now, unsurprisingly, what the researchers found was that almost nobody responded to the first letter. 10 times as many people were likely to respond to the second letter. And that's really important because, as you say, this is about how you deliver your support. It's really critical in terms of how it's received. And that's probably one of the biggest messages to take away from this training session. Now, normally what we do when we finish sessions is have a learning summary like this with different outcomes to work through. But in this case, we're going to use a picture, and it's the same picture that is at the beginning of this presentation. It describes the 3 things needed for effective drug support. And we're going to start here at the beginning. The first thing that is needed is that the person providing the support or the service providing the support needs to be caring and capable. This is different to how many people start. They often start with a desire to change and think this is about someone's motivation to change. And what we're saying is no, you need to start here with the service and who's actually providing the support. So this person or this service needs to know how to help. They need to be genuinely invested in the other person's well-being. They need to encourage and avoid blame. Now, the person providing the support could be a professional or a peer, but for more serious addictions, it helps to have both. Then, the support that's being offered needs to be within reach, and that needs to be within present circumstances. Suggesting to someone that they must make changes in order to access support isn't actually support. So this needs to be available at the present time that someone is asking for that support. And the final thing that needs to be there is a desire to change. But desire to change should not be confused with an ability to change. Those are 2 different things. Someone could really want to change, but not really have the resources in order to really act that through. So we should probably assume, as a rule, that if a person's life would obviously improve with change, that the desire probably is there and will become stronger when those first 2 conditions are met. And finally, the change that we're talking about needs to be within reach. And that takes us back to that slogan about any positive change. So with all those things in place, you maximize the opportunity for positive change in someone's life. And hopefully this session has really summarized drug support and how best to support people who are struggling with drug use issues. You can continue learning at Drink Drug Hub. Again, you can find all our resources at drinkdrughub.co.uk, including the video that we referenced in this session. In the meantime, I want to thank you for watching this video and encourage you to come and watch further sessions with us. Thank you.